When a psychologist treats a patient with chronic pain, they are generally helpful in one of three ways. First, by helping the patient to develop more effective behavioral skills, such as skills to improve pacing, sleeping, or exercise. Secondly, by improving the patient's emotional experiences related to their pain, such as by reducing guilt, depression, or anxiety. And thirdly, the pain psychologist may help the patient to change how they think about their pain, both by reducing thinking habits that may be making the patient's pain or function worse, and by increasing thinking habits that improve the patient's pain or function. This video will focus on the thinking side of chronic pain, illustrating some of the most common thinking patterns present among patients with chronic pain that worsen their pain experience, and reviewing some strategies for countering and replacing these thinking patterns. Among pain psychologists with training backgrounds in cognitive therapies, they are probably already aware of the important role that thinking patterns play in mental health conditions such as depression and anxiety disorders. Researchers such as Aaron Beck and authors such as David Burns have spent much of their careers describing the intimate role that our thoughts play in relation to our emotions and quality of life. Although patients with chronic pain may or may not struggle with depression or anxiety, they nevertheless often show their own patterns of thinking that can strongly affect their quality of life as well. Perhaps the most common thinking pattern that is harmful to patients with chronic pain is the tendency to catastrophize their pain symptoms. Stated succinctly, catastrophizing in the context of pain refers to the tendency to interpret pain symptoms in ways that are very severe, usually creating high levels of fear and anxiety as a result. Catastrophizing tendencies can be measured quickly using measures such as the pain catastrophizing scale. When catastrophizing is found to be a common way of thinking with a patient, then this pattern should be brought to their awareness through discussion, the use of thought records, or both, along with explicit practices for how different interpretations of their symptoms might lead to more flexible options for responding to their pain symptoms. In creating alternatives to catastrophic thinking, the patient is usually the best resource for generating their own pain symptom interpretations that are credible and useful to them. However, keep in mind that many patients do first benefit from concrete examples of non-catastrophic thinking about pain symptoms. A second common thinking pattern among patients with chronic pain is to interpret their pain symptoms as signs that they are hurting themselves or worsening an existing injury. When this pattern is present, it can cause considerable harm by making the patient less physically active and more impaired. This thinking pattern can also pull a patient into a vicious circle of inactivity resulting from their fear of injury that produces deconditioning, increased pain, and thereby more disability. The tendency to interpret pain symptoms as a sign of injury are most common among patients with higher levels of anxiety or somatic symptom focus, and this tendency can often be captured using questionnaires such as the Pain Anxiety Symptom Scale or the Patient Health Questionnaire 15. This thinking tendency can also be indicated in patients that report high levels of disability or activity avoidance that are discrepant from their medical findings. It often works best to counter this thinking bias by using a patient's fear of injury as a hypothesis that can be tested through in-session or homework activities. Collaboration from the pain physician can also be helpful here as a source of reinforcement to promote more accurate symptom interpretation by the patient, as well as by fostering more active behavioral goals. The third common thinking bias among patients with chronic pain I call the Dr. House effect, in reference to the television doctor of the same name who regularly performs miracles with patients presenting with seemingly hopeless conditions. Among patients in real life, unfortunately, the Dr. House effect produces few medical miracles for patients and more often promotes a wasteful pattern of doctor shopping and a reluctance to practice management approaches to pain. As long as a patient maintains a view that their pain condition has been misdiagnosed and can be resolved just by finding the right doctor, they are unlikely to consider pain psychology treatments or even related behavioral approaches to pain management. Sometimes a provider can just practice patience while the patient explores the doctor circuit, looking for their own particular Dr. House and hoping that the patient will eventually come to a new perspective on their own. However, it may also be possible to approach the situation more collaboratively, such as suggesting to the patient that pain psychology therapies could be practiced to help them right now, even while the patient may be continuing to explore other treatment options through medical specialists. Because some patients may see accepting a pain psychology referral as a form of giving up on more aggressive approaches for their pain, it is important to describe pain psychology therapies with these patients in a way that is compatible with their own goals. The fourth harmful thinking pattern among patients with chronic pain is the tendency to view their pain and functionality in black and white terms. The inability to appreciate smaller steps or grades of progress can be a major barrier to pain management. For patients with strong black and white thinking tendencies, for example, struggles to perform an activity may be seen as a complete failure, even if they manage to actually complete the activity. Similarly, pain may be seen as unacceptable at any severity other than none at all, and the patient's expectations about treatment may be unrealistic and unnecessarily rigid. Like the catastrophizing tendencies described earlier, black and white thinking patterns are best treated by bringing them to our awareness through therapy exercises and discussion, illustrating how these patterns create distress and stagnation rather than helping the patient move forward towards their goals, and reviewing and practicing more flexible ways of responding to the situations where black and white thinking occurs. In reference to the famous Bruce Springsteen song by the same name, the glory days bias is another common and often limiting way of thinking among patients with chronic pain. With the glory days bias, patients tend to show a pattern of evaluating their current function and quality of life in comparison to themselves at an earlier point in their lives when their pain and injuries were not present. Predictably, this way of thinking creates unrealistic expectations, feelings of failure, and difficulties for the patient to be able to appreciate the usually slow and gradual process of improvement. Patients limited by the glory days bias may especially benefit from mindfulness and related meditation exercises that can help them to become more present-centered. These patients may also benefit from using activity logs or charts that can be reviewed routinely to highlight their progress. These latter kinds of visual progress aids can be effectively combined with clinical discussions in pain psychology visits to help the patient to develop new comparison standards by which to evaluate their efforts. The sixth common pain psychology thinking bias is called quick fix disease. In regards to pain management, quick fix disease refers to a pattern of thinking that causes the patient to pursue pain treatments primarily based on criteria such as their convenience, cost, and immediacy of benefit. One might argue that the ongoing opioid crisis was partly fueled by the widespread influence of quick fix disease in the U.S. culture of pain management, with the rapid benefits of opioids emphasized at the expense of the many harmful long-term effects that can result from these medicines. For patients with quick fix disease, pain psychology treatments are unlikely to be something that they will choose to participate in or benefit from until their quick fix disease thinking is replaced with a longer-term perspective. In some cases, the patient's own years of poor treatment experiences or complications from their prior quick-fix approaches to pain management can be used to illustrate this bias directly and to help them consider a new perspective. In other cases, examples from famous athletes or celebrities are sometimes useful as role models to reinforce rehabilitative treatment approaches such as pain psychology or physical therapy for pain. Finally, there are many examples of quick fix disease outside the world of pain management that can also serve as non-threatening demonstrations of the shortcomings of this way of thinking. The results from crash diets for weight loss, for example, before and after fitness advertisements that market supplements, and get-rich-quick schemes, among many others, are examples of quick fix disease useful for identifying the typically poor results from following this thinking pattern and encouraging a longer-term treatment approach. The seventh and final pain psychology thinking pattern reviewed here is called the medical model bias. Patients with chronic pain that operate under a medical model bias are typically closed-minded to any treatment that isn't strictly medical, such as medicines, procedures, and surgeries. They understand their pain rigidly through the lens of their X-rays and MRI results and perhaps other medical findings, and they similarly tend to dismiss suggestions that psychological factors play a role in their pain at all. Because of this, they are less likely to accept referrals to pain psychology services, or at least to be more skeptical about the potential benefits of these services. I place this particular bias last on this list, not because it is the least important or least common, but because it is often a barrier to treatment that must be approached through the active collaboration of the pain psychologist and the physician. For instance, because medical model bias will often deter patients from considering a pain psychology referral, it is the physician that must consider how they can describe pain psychology services in a way that minimizes threat and maximizes the medical credibility of the treatment. Towards this cause, the physician will often benefit from discussions with the pain psychologist, who can offer some specific ways of describing pain psychology treatments that emphasize their biological or medical rationale. For additional assistance, you may refer to a previous video in this pain psychology series titled Improving Pain Psychology Referrals that offers several specific descriptions of pain psychology services for physicians to consider in their patient discussions.